Good afternoon to all of you. I'm Dost Unger from McLean Hospital, Harvard Medical School, and my task is to introduce the lightning talks. We have a wonderful lineup of exciting and interesting work going on in the Boston area. We are starting later than scheduled, so we expect to run past the 3:30 end time, so everybody's aware, but we're going to try and stick to the length of each talk. So we're going to start with Professor Evins, who's the Cox Family Professor of Psychiatry at Harvard Medical School, founding director of the Center for Addiction Medicine at Mass General, and director for faculty development in the Department of Psychiatry at Mass General.
Thank you so much. So I'm a member of the schizophrenia program at Mass General and the addiction program at Mass General, but this little series of experiments I'm going to bring to you came about from a phone call about 6 years ago from the Attorney General's office in Denver after they had commercialized cannabis, and the Attorney General's, the folks were having case after case of fatality due to what they were sure was sort of a cannabis intoxication sort of scenario, but they couldn't get convictions because the field sobriety test does not work at all for cannabis and was not being allowed into court, as it's not here anymore either. And he'd seen one of us give a talk we work through the Center for Law, Brain, and Behavior with Judy Edersheim and give talks teaching a little bit of brain science to federal judges and their staffs. And so his question to me was, could we figure out something with brain imaging that could help them? And I sort of laughed and thanked him for his confidence in me and sort of told the story over lunch to my staff. And the next day, Jody Gilman, who many of you know, came in and said to me, "What about fNIRS?" And my penetrating question to her was, what's fNIRS? And so we went over to the Martino Center and took a 3-day course from David Boaz on fNIRS and raised a little bit of donor money and ran this first study of looking at people who regularly use cannabis. They came in and we did fNIRS before and after a dose that we thought would be intoxicating for them. We gave 30 to 50 milligrams, which was quite a big dose. Dronabinol, the FDA-approved THC, comes in 2s, 5s, and 20s, which tells you sort of the usual dosing for people who don't use cannabis. But the main problem with cannabis is it's so tolerance-inducing, about 10-fold more than alcohol. So you can't really do a blood level or a saliva level to determine whether or not you're intoxicated. Somebody who uses cannabis regularly could have a very high sort of serum or urine or blood or saliva level of cannabis and be actually non-impaired to drive from any way that you can measure them. So, our thought was there's lots of CB1 receptors in the prefrontal cortex, which is pretty easy. CB1 is the #1 receptor where THC binds a cannabinoid receptor. Expressed prefrontally, maybe we could see something. And maybe for these people's sort of their intent, where we failed for most psychiatric illnesses to have something that you could use neuroimaging to be diagnostic on an individual level, maybe intoxication impairment caused such a global perturbation that we could actually diagnose folks. So this is our first little, donor-funded study, 13 people pre-post THC dosing. We managed to dose most people to get them high, and there's increased sort of oxygenated hemoglobin in the post-dose state. So people had increased, essentially, brain activation post-THC in this first little study, which enabled us to go and get NIDA funding to do a sort of a 2-stage grant, a small first stage. If you met your targets, you could get the second stage of the funding. And so what we found, again, we dosed people, just 50 people this time, 54 people, individually trying to get them intoxicated, but to tolerate the medication, not to have sort of psychotic symptoms or nausea, vomiting. And what we found was we got most people high, about 50%, which allowed us to compare the subjects in 2 ways. We had drug placebo on 2 separate visits, but we also had those who did and didn't get intoxicated. So we had a group of people who got a little bit high, but we didn't think they were impaired, so we could look at whether a non-impairing dose of THC, what that did to brain activation as well. And what we found is that we saw increased brain activation in people who got quite high, but not in the group of patients who got THC and did not get terribly intoxicated, which was sort of fantastic. You know, and the idea was we like, okay, we wanted to be able to see, could we tell the difference between 1 beer and 6? You know, could we tell the difference in having some THC? Because I mean, in the military now, they can basically say zero tolerance, you know, but in Colorado, it was legal to use cannabis. So if you had some in your system but you weren't impaired, then this was legal for driving now. So this enabled us potentially to differentiate no use from intoxicated use, but also a non-intoxicating dose from an intoxicating dose. And here in the drug placebo comparisons where we were sort of powered, there's an overall drug effect, but you can see it's driven by the effect amongst those who became impaired. And our goal had been to sort of compare THC, was to basically, in the next phase, to use machine learning to try to make a classifier with the gold truth or ground truth as essentially the gold standard legally, which was a field sobriety test by a specially trained officer. But in pilot testing, we did have them see every person. Their false positive rate was 21%, even in those on placebo, which tells you the problem in society. Their false positive rate was closer to 40% if you took all the dosing. So if people, we didn't judge them to be impaired. So this is the second half of that grant. 169 participants were dosed with even a wider range because as cannabis became commercialized in Massachusetts, we were seeing higher and higher levels of tolerance. So we went to 80 milligrams and still had half of our patients not get high. And you can see that here. Which one is the pointer? Is this? So here's the level of self-reported intoxication in people who got who didn't get high or didn't get impaired versus those who did, but they had the same dose. The average dose was 35 milligrams of THC. So therein is sort of the problem for the saliva effect, et cetera. So we basically made two ways of ground truth for impairment. A consensus clinical rating where Jody and I essentially independently looked at all of their data, including their self-report, a nurse's observation throughout, and then we had an algorithm, because when you get quite intoxicated, your heart rate goes up. So we had just an objective algorithm as well. And so we only looked, when we built the machine learning classifier, we only looked at people as positive, that we had consensus ratings, and we used the placebo data for the rest of building the algorithm. And so we just wanted to look at, can we just look at brain data alone to classify participants? And it turns out we didn't do too badly. This was in during an MBAC task. So ideally, we'd like to do resting state, which we're working on now. But this is using the NBAC data, comparing people who were impaired post-THC, so only 77 people. We included those non-impaired post-THC in post-hoc testing, but used the post-placebo data to build the algorithm. So accuracy is about 76%, approaching the 80% that we wanted, with a 10% false positive rate, which is sort of not acceptable just yet to be used in the field. But again, this is just with small numbers of patients. So John Gabrielli sent me an email the morning that this went out to congratulate us on our front page of the Globe. But this sort of got the attention of even the very sort of pro-cannabis for the masses Boston Globe, because he's Dan Adams, who's their cannabis reporter, saw that we were trying to essentially reduce bias as well, because people are being intoxicated, and largely far more people of color are arrested and incarcerated for cannabis use. So we were trying to essentially find who was actually impaired, which you shouldn't matter about your politics. You want the roads to be safer. So we started from the beginning trying to use individual level data using just resting state brain activity. And this was the first very early small study using the resting state data and some various machine learning techniques to classify impaired from not, just using brain data. And this used various data augmentation strategies, but sort of gave us hope that this was actually possible. And one thing was important is in talking to people, we've been working with chiefs of police, et cetera, all along the way. They want shorter data acquisition times, but clearly the longer we collected data, the better we got at classification. So we've just put that together in a paper that's just accepted for publication using all of our data in 170 people, showing that cannabis clearly reduces both correlations and anti-correlations throughout the prefrontal cortex detectable with fNIRS, but also basically increases dynamic functional connectivity and across every channel throughout the prefrontal cortex and through various ways of cutting the data, looking at different sliding windows. This is seems to be a consistent effect, to the point where we're now looking to build a device that will be used in the field, shielded from light, flexible, wireless. This is collected with a NIRX device that's commercially available. I guess this is what I want to show. So the test reliability is quite high across sort of visits 2 weeks apart throughout. So this is just a very small contribution. We've got data now showing that alcohol impairment may do the same thing, just data in 40 people. And starting to have a look at this in concussion. So basically it's a portable, wireless, battery-operated brain imaging technique. Only is able to collect data in superficial cortex, but some of this may be useful for practical applications.
I'll ask one. For these studies, people who are cannabis users are coming in to be those with cannabis. What is the protocol for that? Are they told not to smoke the night before, or how do you actually set it up?
Yeah, we ask them not to smoke for 24 hours, and we will pay them to come in and get THC. Yep, and we do measure their THC when they come in, but so they don't have THC, but they have obviously carboxy THC in their system, which may have some effects. Yep, John.
Yeah. So really wonderful data there. So people who are regular cannabis users become quite tolerant. So how do you think a system which would be developed to keep impaired intoxicated people off the road would penalize people who were not addicted to cannabis for episodic cannabis use, since they would be presumably more sensitive, more likely impaired driving, and protect people who are abusing cannabis and highly tolerant for legal consequences of their cannabis use?
Well, I think it only matters if they're impaired at the time that they're driving, right? So it's legal to use. So it's a sort of like if you're legally taking your opioids or something, just don't get behind the wheel. Yeah, and I think people who use quite heavily, some of the people who did not even feel 80 milligrams, which is stunning. Our IRB couldn't believe it. I'd be out for a week. But they're using 5 times a day. They're young males generally who are using all the time. Yeah, and I think that now that's so normal, we basically need to make sure they're not impaired. And so the thought was to sort of diagnose it at the organ of interest, like you diagnose a broken arm by taking an x-ray, and it seems to work, seems to matter. Where we're not seeing a signal at equivalent doses. I thought that was so cool that the average dose in the impaired and the not impaired was about 35 milligrams. Yeah.
Great, thank you very much.
Thanks.